So much, Professor Saad Mahdi, and it is a great pleasure for me today to introduce my this session, especially all of the people who are speaking today. They are my friends, and it is my great pleasure and honor to introduce we first speaker, Dr. Amro Amer. I worked with him in Saudi Arabia. He is one of the most expert person in the field of the monitoring of the neuro anesthesia. He is American Board of Clinical Neurophysiology and American Board of Neurophysiology neuro monitoring, and he will speak today about the intraoperative neuromonitoring and anesthesia protocol. So please, Dr. Amr, floor is yours and go ahead. Thank you so much.
Thank you, Professor. So I have nothing to disclose. So today I'm going to talk about intraoperative neuromonitoring and what it has to do with anesthesia. So monitoring is it's divided into two sections: monitoring and mapping. So monitoring is a question of saying how is the function of the neurons. Mapping is where is the neurons, where is the specific function of the neuron. For example, motor mapping, speech mapping, sensory mapping, etc. And it's a real time during surgery, and we give feedback to the surgeon immediately if there is any changes. First, we take a baseline before the surgery starts. If there is a change, we let the surgeon know, so we're able to adapt and modify what he's doing or stop what he's doing. It has high specificity and sensitivity in many of the common tests we use. To usually predict and prevent neurological injury. And if there is an injury, it could be slow or sudden, permanent or transient. We have a way of saying with high predictability how that will end up. So that's it. Let's go to the. We have a lot of tests actually. So mainly, as you see the list right here, those are the main and common used modalities we use in the OR. EMG, trigger EMG, sensory, that's for sensory function. Train of 4, you all guys know about it. Direct cortical mapping, motor mapping, transcranial motor mapping. T-wave is another way of motor mapping, but it has different parameters, different setup, whatever. Motor mapping, cortical mapping, and speech mapping. So visual, language, nerve action potential, that's usually for peripheral nerves. EEG for mainly for aneurysm, cranial aneurysm, etc. Electrocorticography, it's usually for epilepsy cases, bulbocavernosus reflex, any lumbar case, or any tumor in a lumbar case or pelvic surgery. We usually do that to see the integrity of the utender nerve. Hoffman reflex, that's another test for peripheral nerves. Deep brain stimulation of brainstem auditory potential, brainstem function, and cochlear nerve. So we cover a wide variety of surgeries. As you see, neurospine, vascular ENT, and it depends. It's different from one hospital to another. Some centers have a lot of neuro. Some centers have a lot of spine, usually orthopedic surgeons. And some centers actually have a lot of ENT vascular surgery. My experience, I used to work a lot of neuro and vascular, and spine, of course, is part of it. So, what affects the neuron function? The surgeon, fusion, medications, And all of that will end up at the signal coming out from the patient, whatever the signal is, either sensory, motors, language, whatever it is. So all of that will affect me in a way. So let's say an anesthesiologist will give a bolus that will change my tests completely. Actually, disturbed in a way that I don't know, is it really coming from the patient or the surgeon or really from just medications? So communication, of course, is the best way to deal with that. So starting, I'm gonna just talk about quickly about some few tests, and then we'll talk about what drugs that affect those tests, generally speaking, and then physiological parameters that affect our Trinophore. You all know about it. We just want to see if there is any muscle relaxing effect on board, and or we recovered, or we did either we is a muscle relaxing effect is working, or actually we are it's out of the system. And then Trinophore is not just a Trinophore. We do what's called Trinophore ratio. We compare usually the first wave to the fourth wave. So if it's more than 60%, that's what we're looking for. If it's less than 80%, we still can do EMG, but preferably more than 80% to do motor evoked. And so I have a lot of experience with anesthesiologists saying, "Oh, the patient is fine. I have 4 twitches. I can see it visually." Yes, but Trinophore ratio is actually less than 60%. So that will affect my signal. What we do in Trinophore, we usually stimulate at any neuromuscular junction that is close to what we're looking for. So, for example, if we're doing a lumbar surgery, we usually tend to do the Trinophore at posterior tibial nerve neuromuscular junction. We stimulate pre the junction, and we record post junction in any one of the muscles. So that's how it works. All right. Second, another one is transcranial motor evoked potential. As you all know, it starts from it's just another way. If the patient is awake, so let's say he will give the order to move his hand. The signal will come out from his primary motor cortex, goes all the way to the internal capsule, passing the thalamus, bypassing the thalamus, goes to the posterior limb of internal capsule, to the brainstem, the lower medulla, deposit to the other side. There's 2 tracks, lateral and anterior. What we're looking for is actually the lateral that supplies the four limbs, and that's our main concern. Another test is the D wave. So instead of stimulating at the head and recording from the peripheral muscles, we actually stimulate from the head, but we record from the spinal cord with a specific record. And we do these cases usually for intramedullary or intradural extramedullary tumors. And it usually detects the direct waves of the corticospinal tract. So if there is any synapses, bypass that. It's very accurate. So even if we lose motor during the case, we tend to rely on the D wave. There's parameters. I'm not going to talk about that. So it's different parameters for different critical part of each surgery. And this is another picture of the pathway. And on the top right, there is doing what's called direct cortical motor evoked potential using a great strip. Another picture. So anyway, excitability. So usually motor evoked potential intensity in pediatrics, we tend to make it higher because the myelination is incomplete. The maturity of the nerves is incomplete. So signal will be less in amplitude, which is the height, and usually takes longer, which is the latency. So we tend to increase our intensity or power of electrical intensity to increase the excitability of the nerves. Another picture of intramedullary tumor. That's another picture of the E wave, and we usually on the right side, that's where we usually stimulate that head. We have another thing, what's called fading, motor fading. So the longer the surgery, the signal will be less, no matter what. Even if the patient is fine, nothing happened, but just from the accumulation of drugs inside the patient, even if we're using any drug, literally, there will be fading. And it's even worse with myelopathy. Myelopathic patients usually have bigger fading. We compensate that by increasing our intensity in a way that does not jeopardize the signal or make a false positive signal. But other thing is, which is the main thing with anesthesia and neurophysiology in the OR, a lot of we usually tend to forget about byproducts. So motor potential is a very powerful, intense stimulation, and when we do that, we have if we don't have any protection for the tongue, we tend to have either tongue hematoma, tongue laceration. So to prevent that, we use a pit lock. On the left, that's one of the needles we use it to record if we do any transfer. As you can see here, hematoma and laceration of the tongue. Sometimes we see complete cut of the tongue. We've seen a lot of bad cases. There is different types of bite blocks. You can use a simple gauze, eye gel, or manufacturer already installed manufacturer. That's another functional MRI for the corticospinal tract in the spine and the spinal cord, and that's another functional MRI going from that's for sensory and motor. They usually go hand in hand, very close to each other. And usually if there is a change in motor, you usually see a change in sensory and vice versa. The sensitivity of both of them together tend to be up to 95%. So in any case, we're doing sensory, we prefer to add motor to it to increase our sensitivity. Another way of doing motor is cortical motor. So it's the same way we stimulate the head at a specific point, but we record from the cranial muscles. Different cranial muscles you can see, terminal facial, and that's our main cranial nerves, or other cranial nerves. As you can see, we have a signal here, so I'm not sure if you can see that by arrow. We have what's called CMAP. As long as we have this signal, that we are fine. If we lose that, or if we decrease in height or amplitude, that's another grid we use for different surgeries for what's called phase reversal to know where the central sulcus is, or we're going to talk about that a bit, and or we use it in epilepsy. For epilepsy, we tend to excite the cortex to really to get the seizure, the epilepsy location, exact location. Other test is sensory vocal potential. It gives picture about the dorsal column. So sensation is actually pain, temperature, tactile, deep touch, proprioception, whatever. But sensory vocal potential is only covering the proprioception part, which goes through the dorsal column from nerves, dorsal column, medulla oblongata, the medulla, then go all the way to the VPL, the nucleus in the thalamus, and then goes to the Turner capsule, posterior limb, and then goes to the postcentral gyrus. We pick up this line before we start the excision. There's a neuromonitoring surgery. Have a army criteria, what's 10% increase in latency time, or 50% decrease in amplitude. And that's the pathway And so what we do is we stimulate on the upper limbs, we stimulate the ulnar or median. And again, that's another thing. So usually anesthesia lines usually run in this area. So if we don't have an access to the median or ulnar, we usually stimulate for ulnar nerve, we stimulate at the medial condyle at the elbow. That's for the upper limb. And for the lower limbs, we stimulate the posterior tibial nerve. That's where the medial malleolus is, right behind it. And or if we can't do that, or if the patient has diabetic neuropathy, then we usually stimulate peroneal nerve, which gives us. So we stimulate peripherally. We record, as you can see on the left of the head. So so Sentry is kind of opposite way of stimulation and recording compared to the motor. Another way of Sentry is what's called phase reversal. We talked about it shortly. So we want to know exactly where the central sulcus is. Different signal. It's the same concept. We stimulate the nerve peripherally, but we record the direct. We put a direct thread on the cortex, hopefully looking for the. Another way of doing Sentry is to really know the median raphe and the intramedullary. So let's say we want to do intramedullary tumor. The surgeon want to cut through the median raphe, and he really want to know where is that. There is a distortion of the median raphe by the tumor, so he really doesn't know exactly what it is. So we stimulate. At that time, we stimulate actually the spinal cord after opening the dura right and left. And we exactly know at that time, is it right or left? We stimulate the spinal cord and we record from the brain. That's another picture of how the signal looks like. So on the left side, you see that's what's called Sentry, bilateral upper and lower limbs. On the right side, we see different muscles on the right and left for transcranial motor potential. On the top, just the EEG. On the top right, there's an EEG. We'll come to that. Bulbar cavernous reflexes that we stimulate at the udendal nerve, male or female. For the female, we stimulate the major clitoris, and for the male, we stimulate at the shaft of the penis. So the signal, we stimulate actually the sensory branch of the udendal nerve. Goes all the way to the spinal cord, and interneurons to give a signal going back through the udendal nerve about the motor brain. We record it from the anus sphincter or urethra, but the accessible one is anus sphincter. So as you can see, the signal right here. Now we know that the udendal nerve is actually intact. There is no incontinence or any neural damage for the udendal nerve. For each surgery, there is so let's say anterior cervical C46. Then I will do, let's say, motor, Sentry, EMG. I choose my muscles depending on the surgery level, and I usually go one level up, one level below that. So let's say I'm doing C46, I usually go all the way trapezius, deltoid, biceps, triceps, and pectoralis. That's for EMG. EMG is just, we test the function of the nerve, the nerve roots. It has nothing to do with spinal cord. From Sentry, usually check the integrity of the spinal. Of course, if there is a change in the peripheral nerves, it will affect it indirectly. But EMG is entirely for nerves. So let's say even if we have complete hemisection of the spinal cord, the EMG will not be affected in any way. Silent EMG is just flat line of EMG. And if there's an irritation on the nerves, depending on what type of irritation, can tell if he's retracting, if there's really mechanical injury, if he's stretch, or just the manipulation. And there's different types of EMG. I'm not going to talk about it, but I mean, let's see the picture on the right, for example, is giving us different pictures. different types of motor mapping and language mapping. So we usually do the language mapping in awake patient. And if we're going to do that, and if the tumor or the lesion is close to eloquent areas of the language or the motor, premotor or supplementary motor area, or primary motor area, we stimulate. We want to really, before we start resecting the tumor, we want to stimulate these cortex areas, vertically or subcortically, while he's dissecting the tumor, to prevent injury before it happens. So if he's close to any of these eloquent areas, we can tell that, and we'll tell him to stop if possible, and usually. So this is the homunculus of the brain. So there is, for motor mapping, there's 3 ways of doing that: either direct, by strip electrodes or grid electrodes. There was a slide before that showing it. What's called monopolar stimulation or bipolar stimulation. Each one has its own pros and cons, and I tend to choose one of them depending on the surgery and what. Subcortical mapping is very efficient actually in preventing injury to the descending corticospinal tract. So let's say we're stimulating the tumor area here. Let's say so the cavity right there is where the tumor was. We have a remnant of the tumor, and the one in the purple is let's say the corticospinal tract, and we're stimulating the tumor bed. We get a signal at 7, so I can tell the surgeon almost definitely that we are 7 millimeters away from the corticospinal tract. The alarming number is 5, and some centers actually down to 3. But if you go beyond that, most probably you would have permanent injury. So the picture showing a signal here on the one in the green. That's one of monopolar probe. There was a meta-analysis done by a group of surgeons. So one of them is a French surgeon, neurosurgeon. He showed that with mapping, we decrease the post-operative neurodeficit by actually more than 100%. Increase it by 100%. And the surgeon tend to, he has a way of, so he can do as much section as possible with less injury. That's the benefit of language mapping. We do it in wake. If we have what's called speech arrest, once we stimulate and the feet stuttering, we stop. Actually, there's different tests for language mapping. But I mean, usually there is someone who's doing the test, and I'm with him. We do it perfectly as another test of EMG, what's called triggered EMG for different cranial nerves. Depend on trigeminal, facial. So what you will really see like with anesthesia is the needles we have to insert in the soft palate and the tongue for glossal nerve, and for the vagus nerve actually we have a special tube. Hopefully I have it in the next slide. Yes. So it's a tube. It's a regular tube, but just added the vocal cord that usually. So let's say you put your tube at 21 or 22, and so it has a margin covering the full vocal cords. So if there's any injury to the vagus that will go to the recurrent laryngeal, I can see that the EMG. That's another way of doing the cochlear nerve. We do what's called click, auditory lobe potential. We put these forms on the left on both ears, and we record from different areas of the brain. And if we want to do what's called cranial nerve mapping, where if the surgeon really doesn't know where the nerves is it inside the tumor or around it or whatever. So we do mapping. We get a signal. Okay, here it is. We have a signal at 0.79. So we kind of far away from auditory vocal potential. We have 5 signals, each from one area, different area. So one comes from the nerve, third comes from the pons, superior liver. The fifth one, which is the most important, so if, back to this one, if there's any change in one of or all of it, we know exactly where the change is coming from. Well, they have different criteria on the right. You can see, so there is latency of each one, entropy between each one and the other, and amplitude, the height of the signal. And morphology, triphasic, is it triphasic? Does it change to biphasic? On the left side, we have also link reflex or corneal reflex, which stimulate the kilomotor nerve, and usually we have a signal and usually goes to the brainstem. Actually, I would stimulate the trigeminal nerve, goes to the brainstem and goes back. The signal comes back as a fissure nerve. So if there is signal, that means that both 5 and 6, at least V3 of the trigeminal and 7 nerve, I'm sorry, the 7 nerve, fissure nerve. That means that integrity of both these nerves are, and of course, another auditory brainstem stimulator. Usually we do that for NF2 patients. We do that to stimulate. So these patients have bilateral hearing loss. We stimulate the brainstem, and we look exactly for the cochlear nucleus, and we stimulate that nucleus, and hopefully we're looking for partial recovery of his. Another test is visual evoked potential. We stimulate using goggles, and we record from the and we have a signal, and then there is a change in that signal. We usually use a criteria of all or none, and we really cannot tell much other than that. There or not there, something's going on, or everything's. So this is another picture of the tumor. We did the speech mapping, and on the right side, post-operative. We know after knowing exactly where the speech is. Another paper was done by Dr. Fu. He's expert in that, language mapping. Really, it prevents injury. Most of the patients, like we look into prevent injury, not to detect injury. Some tests cannot detect, cannot prevent injury. Language mapping and motor mapping and any mapping actually is a way to prevent injury before it happens, and that's what EEG. So we have this case recorded in our. We have a change, as you can see, there's a slowing. So if there is a slowing in the EEG, that means that we ask the surgeon, we tell him surgeon, and usually he shunt after. Here we have a slowing, but we're not using EEG like normally that we do. We do what's called electrophysiology using 8x8 strip. Okay. And again, usually we put that on the therapy on the cortex, and we use that in epilepsy surgery, and sometimes actually we use it in just tumor resection in the front of the another way, actually, what's called positional. So there's 2 positional changes. Either we, and usually that's in myelopathic, unstable neck. So say we're doing a patient posterior cervical, and the patient is unstable, he's myelopathic, and once we flip, we take a pre-positioning baseline, we compare it immediately with a. So as you can see here, right after positioning, we have a change in signal below level of the right side, the hands are done. So there's a change. Something so of course, will reposition fix that. And the other way of checking the position, in prone position, usually in a lumbar surgery. So let's say a patient is prone and his arms are extended. So it's over extended to the top of his arm. We will see a change, and we position the arm. That's another way of DPS. We usually do that for bronchus depression. For example, we want to look for skin nucleus, and once we locate it using microelectrode, then the surgeon can look at it. And if we stimulate it in a specific parameter, the patient hopefully will stop his symptom. That's surgery frame. That's another one with red. For epilepsy, there's another way of treating epilepsy. It's the vagus nerve stimulation. So we look at the vagus nerve, and then, and of course, once we look at the vagus nerve using the then we put what's kind of a loop electrode around the vagus nerve, and it's permanent. And there, it's battery, and the patient will stay with it, putting up the parameter, and hopefully with the vagus nerve stimulation, they see. Yes. Selected dorsal rhizotomy. So on the left picture, on the right side, the surgeon really want to locate the dorsal century and differentiate it from the motor branches. We use that for spastic cerebral palsy patients, and we test each one of them, and we really can tell the surgeon, oh, this is sensory or this is motor. So once we locate the sensory, then we start dissecting. Surgery. Okay, so now to anesthesia. So usually hypnosis, analgesia, immobilization, muscle relaxant, electrolyte, cardiopulmonary stability, and different drugs. One of the common drugs we use in OR. So as you can see, I'll go quickly through this. Mainly all of them are GABAergic. Halogens, isociable, this intravenous. Etomidate actually is GABAergic, but for us, it's increasing our signal, etomidate and ketamine. So we tend to like it actually. If we increase the dosage, we can tell from our EEG. We usually run EEG in each case. So I can tell the anesthetic. If you're not using BIS or Massimo, then I can tell the anesthesiologist how deep is the patient. Right deep. And really how deep he is. I cannot give him a number, but at least I can tell him, you know what, I have burst suppression, either regular bolus or high maintenance dose, and how much the burst suppression is. And we are out of it. So these are one of the common modalities we use intra-op. So the most sensitive one actually is very sensitive to the point that we even at induction, if we use some halogens at induction, mostly affect the visual for the entire case. EEG right after that. We tend to use TIVA. Sensory is less affected by most of the drugs. It is affected, but less. EMG is not affected by either drugs except muscle relaxant. It's usually a function of the nervous again, but has nothing to do with the brain or spine. Auditory potential is actually completely resistant to any changes in drugs, or what drugs you're using. unless you're really using beyond 1.5 Mac. Then I can see it. So benzodiazepines, you can actually, so there's different drugs. Midazolam, we like it the most if you use it. Of course, it affects motor and sensory, but I mean, usually anesthesiologists use it in a mild dosage and transient. So I don't put for benzodiazepine, we actually avoid it in electrocardiography in epilepsy surgery because we look actually for the epilepsy zone. So really, we want to get, we want to see a seizure. We don't want to see a seizure. We want to see slowing in EEG. You want to see epilepsy zone. So if you give benzodiazepine, that will subside. I would say no epilepsy. Barbiturate, again, affect both sensory and motor, and it does affect it in two ways. So it decreases amplitude and increase the latency. But again, I mean, some surgeons, some anesthesiologists like it, but with my experience, very few use in the neuro anesthesia. Propofol, this is the main one we used. Of course, it's nice and it's different from pediatrics to adults, from one patient to another. For the adults, we tend to go from actually 50 mic per kg per minute to up to 200. For pediatrics, you can go up to 300 mic per kg. Hopefully, try to avoid bolus. If you have to use it, at least let the neurophysiologist know, because he will see huge depression of his motor and sensory. Narcotics, the preferred one is the fentanyl, fast, and everybody love it. It has mild effect, and usually we use it in. This is another picture of CMO, 2-channel. Gives you okay, so here the main talk about will be. So, for example, in this one, you can see the signal, the isoflurane is actually increasing the latency. It's what's called right shift. It's going to the right, increasing the MAC of the isoflurane will increase the latency. That's another one on the right side. You can see the isoflurane effect on the visual evoked pattern. On the bottom, that's the baseline. Then you see on the top one, it's really we didn't go that much. We went up to 0.6 MAC. That's for it. Not that much. So this study was done to compare between using propofol and against using propofol and Presidex, and actually propofol and CFO. And it showed that TIVA, the complete TIVA, so no fluorine, will make the signal higher from the beginning. So if we don't do that, let's say we're using propofol and half MAC isoflurane or CFO or desflurane. Yes, I will have baseline. We will all have motor evoked potential baseline. Then during surgery, if there is a iatrogenic change from the patient, really coming from the patient, I cannot tell is it coming from the patient or is it coming from because usually the signal does not, the baseline usually goes down. So let's say I have a baseline amplitude of 100. It goes down slowly to 90, to 80, to 70. So I'm not sure at that time, is it from the patient or is it from the season? That's another study was done showing the Presidex use with the propofol and comparing the propofol and Prisdex against propofol and Remy, and they actually didn't show much of it. Hypothermia effect, mainly it affects all of the tests. Auditory evoked potential is the most resistant, yet it is affected if it goes below 34. Motor evoked potential and sensory fastest to be affected, and usually the lower limb affected more than actually the upper limbs, because usually the hypothermia actually starts from the nose. Usually the air warmer is not on or whatever. Another way of showing the temperature effect. So on the top, you can see the sensory signal actually, the latency is increasing with the hypothermia. On the bottom, you can see with increasing the temperature, like again, the signal is coming back to the left, back to where. So mean arterial pressure effect is the main thing actually affecting the motor movement. So most of the changes we see in the OR, we usually see that from the hypotension. And as you can see here, there was a study done that showed the effect of MAP decrease on the motor evoked potential amplitude going with time. Of course, cerebral blood flow, if it goes beyond below 20, the EEG will be affected. Then if it goes below 12, then the sensory will be affected. Then after that, this is another diagram of cerebral blood flow effect on neuron function, attention effect on neuron function, and you can tell here there is another twist. So if let's say a patient is myelopathic, actually the effect of hypertension is sometimes tripled or quadrupled on the signal. So if there is only hypotension effect, I can see decrease on my signal. But if there's if the patient is already myelopathic, the change will be huge. Sometimes and you also say, okay, I only went down by 15. It was 80, and now I'm 65. Yes, for him it's not much, but myelopathic, so we've seen a huge drop. We prefer in the surgery, of course, depending on. I know you guys agree with that to keep it maintenance, keep the drugs maintenance dosage as stable as possible. For example, if we do in TIBA, there is a machine it's called TCI. It's one of it really gives accurate, controlled, stable drug maintenance dosage, and in a way that will affect his vitals, and again that will make our signal stable. Another study was done that's another one showing. On the right side, you can see the nitrous. I didn't see that for a long time, actually. Nitrous effect on the sensory signal on the bottom of this line. It's almost increasing the nitrous intensity. On the left, it's the same on the top. That's a baseline. The more we increase the MAC, the more obliteration we see in our signal. Here are the effect of on the sensory signal. On the middle, you can see that's when we started using and the amplitude actually is huge, went higher than the baseline. On the top, boom, 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 then up, went up. Retumidate is actually good for increasing our amplitude signal. It does not affect latency, so usually it's good. And again, I mean, if you have to use it, give huge concentration of it, because I really don't know. I don't want to give false positive signal. Is the patient really improving, or it's really just from another one of showing the different effects of like on the right, ketamine. The baseline is bottom, The more you go with ketamine induction, you see the signals higher. On the left side, that's one of the things. So if you remember, we talked about what's called D wave stimulate. It's the same like motor potential, but instead of recording from the muscles, we record from the spinal cord. It's not affected in any way by using halogens. So on the left side, you can see we're using halogens. It has very mild effect on it. There was a study done years ago showing that the halogens works in, of course, they work on the cortex, but again work on the anterior horn cell. So we actually record from prior to that, at the spinal cord, before the signal goes to the anterior horn cell and goes to the muscles. So D wave is mostly not affected by halogens. Motor evoked potential on the left side, that's the D wave. On the right side, that's the motor evoked. You see, using the same drug, isoflurane, the motor on the right is going down, yet the D wave on the left is mainly not affected. Awake surgery, again, we'll talk about it. There's two ways of doing it. Either we do it awake, sleep awake, or awake and give us or just local. For us, we prefer to use the awake, sleep awake. We just want him to be just sedated just a little to insert our needles in different areas, different muscles. And then after that, again, the surgery depends on the patient age, so the patient has to be cooperative. We cannot do that surgery on any pediatrics or mentally retarded patients. The patient has to be next to eloquent areas of language, arcuate tract, Broca, Wernicke areas, etc. And the type of tumor, usually we tend to do that with high grade, not low grade. All right, so when we do awake surgery, other than doing language, we do what again, motor mapping. So motor mapping, M1 is the primary motor area. We stimulate it. If there's movement, okay, that means this area is the primary motor area. Supplementary, actually, we ask patients to or do something fine motor movement, and then we stimulate. And that movement should stop. If it does stop, then this is the supplementary motor area. Arcuate, Broca, and the Wernicke are all having speech and rest, but Wernicke is kind of like hard and really challenging when we do language mapping because there's different types of speech rest. One of them is okay, so DBS, deep brain stimulation, we use MAC. Patient is just no general anesthesia. We're not going to talk about it. So the last message to say is, if you want to take something home, please ask, if you're not using BIS or schema, please ask at the report, how is it trained for at any time? How is the depth of the anesthesia? And if you're using TCI machine, it will be much better. You don't forget white blocks. Try to know that that maybe a small change in the maintenance dose will affect neurophysiology signal, the monitoring signal, not synchronously. So if you get just increase in the dosage, it may actually decrease my signal tremendously. Ketamine and etomidate are increasing our signal. Most of the others usually decrease in a different ways. Neuromuscular junction affect only motor and EMG. So if I'm doing sensory, actually, it's not affected by using muscle relaxant. So I'm only using communication is the best thing to do from either side. If you give a pulse, please let me know. If I'm stimulating, usually when we stimulate the hands and or something close to the pulse oximeter, you can see an artifact affecting your oxygen saturation or heart rate. If that happens, when I do that, it let you know that that's mainly everything, and thank you so much.
Thank you, Dr. Amr, for this very informative lecture. And as I said before, we worked together for a long time. And I think before using this monitoring, because I worked in the field of the neurosurgery without the IOM for short time, and there is a great difference between using this monitoring uh, for the best outcome of the patient. And I saw this by myself. Some of the cases were very critical, such as spine surgery, intramedullary spine surgery. And these types of surgery necessitates the presence of this monitoring all of the time, because the neurophysiologists warning the surgeon all the time. It is very critical, and it needs alertness from the neurophysiologists, the anesthesiologists, and the surgeon. And I think one of the best home message mentioned in this lecture is the communication. And I think that we were good communicators together during that time. I didn't bother him too much, and I believe that we work together in a good atmosphere. Um, I think there is no questions for this topic, because I think it may be hard to, or Dr. Amr, he covered the topic, and he didn't leave anything to be discussed after this lecture. But I have one question or two questions for Dr. Amr, if you please. When we are using the muscle relaxants, and usually we are using rocuronium in the induction of the anesthesia, and sometimes you need Dr. Amr to do the baseline very quickly for the intraoperative neuromonitoring, and you are requesting to reverse the muscle relaxants. And is, is, is this very important for you to do a baseline to compare for the results? This is number one. Number two, regarding to the visual evoked potential, uh, for how far it is difficult to be applied intraoperative, and what is the relation of the visual evoked potential, and if I used muscle relaxant during this monitoring? Thank you so much.
Thank you. It was a pleasure working with you, Professor. Really, it was at the time. So start with the second question. Visual evoked potential is not affected by muscle relaxation. You like it. So yes, you're using TIVA, but you can give muscle relaxants. We use the visual evoked potential either for a brainstem tumor affecting usually on the fourth ventricle in the midbrain, pituitary tumors affecting the chiasm, Meyer loop, if there's a tumor in the temporal part or temporoparietal areas affecting the Meyer loop, or occipital loop. That's hopefully I answered that question about the visual. The first part for taking a baseline, the issue is, let's say using, I know some centers use the rocuronium group, and some use the succinylcholine, some do not use whatever. If we have to use the rocuronium, and we have to take a pre-positioning baseline, because usually it takes time for from positioning to induction to really recording the signal. takes about at best center ever 15, 20 minutes. And hopefully by then the muscle relaxing effect will be gone. But to be sure, I run 24. That's the first thing actually. 24 first before I run actually any test. Is are we out of the muscle relaxing? If we have 4 twitches, no fading, I can tell I'm 100% sure that all the muscle relaxing effect is gone. A quick thing about the muscle relaxing. So let's say we have 1 twitch out of 4. That means 90% of the neuromuscular junctions are. Actually, if we have 4 twitches with fading, but we have 4 twitches, 75% of the neuromuscular junctions are blocked. 75%, that's a lot. So only 25% are not blocked. 75% are blocked. But to really to make sure that the signal out of the patient is really coming, all of it to me, and I can see all of it, I have to see no fade, or at least 80% fade. 80% fading or 100% fade, 100%. So there is 100%, no fading whatsoever. That means no muscle relaxing effect. That means all neuromuscular junctions are not blocked. So again, so if I'm doing pre-positioning the motor potential, I usually ask to give a reversal, neostigmine, sutamedics, or whatever, or not give muscle relaxant. But if not, then I can wait after the position.
Thank you. I have one more question. I think you are working either in neurosurgery or in orthopedics sometimes, and you are confronted with the cases of scoliosis. And my question, is there any place for the awakening test nowadays in presence of the this monitoring? Still the surgeons, they are requesting, I mean, still surgeon, they are requesting to awaken the patient in spite or although there is this monitoring in the OR.
Okay, looking at history on the old school surgeons, they tend to not see, they don't know what's neurophysiology. So this is a new kind of a new field. It's been about 20 something years only. So usually they don't know it, they don't trust it. Let's say this way. There's a shortage of neurophysiologists, so that's another thing. A wake test. It's kind of like let's say it in the right way. It should not be ever. The patient will go through suffering, and actually he may remember that forever, especially if it's a pediatric patient. That's not.
I think it is unhuman to do this awake test.
Yes, nowadays if you have neurophysiologist on board, why? You have 95% sensitivity of the test. Actually, I have experience of one of the surgeons who really didn't trust what he'd seen. I told him we have a drop, and that's one of the things. Usually, so there is a change. We ask the surgeon, please can you give steroids? We ask him as a physiologist, can you please increase mean arterial? So for adults, we usually go above 80, 85. For pediatrics, beyond 70. And with steroids, of course. And of course, we ask the surgeon. So he didn't trust. He did a wake-up test. It was a pediatric. I felt horrible for the patient. But again, it confirmed what we've seen. And so the test has been, there's meta-analysis. It's a standard of practice. No wake-up test is being done now with any
Thank you so much for this explanation. And we have another question from our colleagues. He is asking, in spine surgery, there is any effect of nerve blocks on monitoring like erectorospinal block?
Yes, it does affect the sensory, but it usually does not affect the motor. It tends to go to the proximal horn, the neuroblock drugs. So if I'm doing sensory test, and usually we're talking about regional here, right? Regional block, nerve block. If we're doing that, and if we have to do some tests, motor sensory evoked potential, we ask not to give it, or at least if we have to give it, then then we put that in mind. So let's say I have my baseline and I see that the signal is not, the patient is fine pre-op, and he was, so I know in advance that using the nerve block will affect my signal, and I will go with that.
Okay. Thank you so much, Dr. Amr.